Welcome to our Caribbean and African Targeted Health Improvement Program, CAHN Health Hour. The Caribbean and African Health Network, CAHN, along with its national partners, are incredibly pleased to continue to bring to you targeted health and well-being education delivered by Caribbean and African doctors. These health hours are all about empowering, educating and giving space to Black people so our communities can look after themselves better. Every Saturday, our Black GPs or consultants present on those health and well-being topics that affect you, your family members and friends. Some weeks will vary and will include other panel members such as pharmacists, specialist nurses and faith leaders. Our health hours cover a range of topics and include mental health, heart health, women's health, reproductive and sexual health issues, men's health, respiratory problems, cancer, sickle cell and many more. We have not forgotten to include within our health hours the many societal, cultural, religious and racial challenges that can go hand in hand with health problems and influence how we should respond to meet health and well-being needs. The sessions are designed for you and we want you to use the time to listen, learn, share your experiences and ask questions to our Black doctors. During every session, we will gather your feedback so we can continue to respond to the needs of our Black community. To request any particular topic, please email health@cahn.org.uk. We encourage you to invite others to our health hour sessions. Spread the word in our community. CAHN is funded by the National Lottery Community Fund.
Hello. Good morning, everybody. Good morning to all 17 of you I can see on the call, and I'm sure we'll be expecting many more people joining us as we go ahead. My name is Datapwa Mujong, and I'll be your host for today's CAHN Health Hour. Just a bit of an intro about myself. I am a GP, and I work in Northwest London. And I also take part in some public health roles as well in Northwest London. Today we've got an exciting day. We've got a very incredible doctor with us who will be giving us some more information about family planning. But before I go into that, just want to just set some housekeeping rules. Please, we want to keep the session as interactive as possible. So please use the chat section. And just engage. If you have any questions, there'll be a Q&A at the very end and we can bring all the questions together. But I'm sure there's lots of people from other platforms apart from Zoom, so I think on LinkedIn and other social media as well. So please send your questions across and we'll be able to answer them towards the end of the session. So like I said, I'll be your host for today, but with me, I've got Dr. Aizemea Okojie, who is an obstetrician and gynecologist. She's based in Brighton. She's a women's health advocate, and she's also an entrepreneur as well. And she's an author, so she's a well-rounded woman, and she will be talking today about contraception, family planning, and myths around that as well. So without further ado, I will pass the mic to Dr. Aizemea Okojie, and she will be taking us on this wonderful session. Dr. Okojie, the floor is yours.
Thank you, Datapwa, and welcome everyone who's joined us today. Hopefully you will benefit and get an exciting session through this Hati Power. Well, without further ado, let's get on to it, and I will share my screen. Please let me know if the screen's been shared, yeah?
Yeah, we can see your screen, Dr. Okojie.
Excellent, wonderful. Now, so my name is Aizemea Okojie. I'm like Datapwa has said, an obstetrician gynecologist based in Brighton. And today's topic is on family planning. And I'm going to be looking at choices and the impact that this has had. But before we get into all of the technical details, did you know, as a fun fact, that the first condoms ever used were made from animal intestines and fish bladders? In fact, the oldest known condom was in Sweden in 1640, and it was made from pig's intestines. Interesting. Also, the word contraception is used to denote methods or devices to prevent pregnancy from interfering with fertilization, implantation, or ovulation. It allows individuals to plan pregnancies, improve maternal health, and prevent sexually transmitted infections. So even though it's commonly associated with pregnancy or the prevention of pregnancy, it has other benefits depending on the method that you use. So I'm basing this teaching today off of the UK guidelines, which are the Faculty of Sexual and Reproductive Health, NICE guidelines, as well as the NHS information, which is freely available online. So contraception, it's come through a very long journey. And I was trying to see, hang on, how long ago did all of this start? And when did man, as it were, start using methods to prevent pregnancy? So historically, the Egyptians used to use honey and acacia leaves along with lint as vaginal barriers in their own way, trying to prevent pregnancies. And condoms were, like I said, made from animal intestines and fish bladders. So mainly in the medieval times. Then by the 18th to 19th century, we started seeing condoms being made from rubber. And after vulcanized rubber was introduced or invented, and then also withdrawal and family fertility tracking methods were commonly used. And in the African setting, a lot of the time, people used to breastfeed their children up until a certain age as a way of family planning to space out their children. But these methods were not really reliable either. So by the 20th century, uh, birth control pills became introduced into the UK by 1961. And by 1974, free contraception was now available under the NHS. And by 1979, the Depo-Provera injection became a choice and was introduced into the UK scene. Modern methods, as I've said, we evolved from the animal intestines, and then we've come so far, and the methods available now are they are highly effective methods, especially when we started moving towards implants or devices that help to prevent pregnancies. And their safety profiles were also improved through rigorous medical testing and to reduce the side effects that most people were suffering with the earlier products. And now you have more choices like pills, patches, injections available. And of course, they found that these things have other benefits or fringe benefits, which are quite helpful in managing conditions like PCOS and heavy menstrual bleeding. Now, this is just a timeline to show the evolution of contraception, but it's similar to what I've just talked about. I don't know if everyone can scan this QR code, and I will start off the questions. So please let me know if you can scan the QR code and if you can see the questions, okay? Any feedback from anyone if we can see?
Yeah, so I've just scanned it as well. And the first question has just popped up.
Excellent. So what percentage of pregnancies worldwide are unintended? So you've got 25%, 45%, 60%, and 10%. Excellent. So I've got a feedback of 100% for, okay, 45, and 10% is coming forward. As a tip, it's more than a few percent. So let's see, the race is between 45 and 10% so far. Any more opinions?
So I'm not sure if it's the same for everybody, but mine was timed and it says voting closed. So I imagine.
Voting closed. Okay. All right. Right. So if I reveal the answer, drum roll. Oh no, I clicked on, sorry. Let me just move that out of the way. Reveal answer. Yes, so 45% of pregnancies globally are unintended. So that's half of pregnancies really being unintended pregnancies, not necessarily unwanted, but unintended. Now, okay, let's do the second one. Can every woman use all types of contraceptive options? Yes or no? Okay, so far I can see no. Right, so it's timed out now. So the reveal is no, yes. That's the correct answer, no. So not all women can use every single type of contraception option. And then lastly, oh, you had unprotected sex but don't want to get pregnant. What should you do? And choose wisely because your future will thank you for it. Right. I'm seeing some very clever people here. So indeed, the answer is get emergency contraception from the nearest available pharmacy or clinic. You can phone a friend for emotional support, but that's not going to stop the pregnancy from taking place. So well done, guys. So let's go back into the presentation. Can you see my screen or has it gone off now?
So the screen is still showing the quiz page. I'm not sure if you've changed it, but it's just got the quiz QR code.
Can you see? Okay, if I flip now, has it changed? Oh no, it's I think what's happening is it's not letting me let me do this. Can you see that?
Mm,
Change now.
It's still on the QR code.
So I think what I'll do is go back into my presentation and then escape.
Yeah, you might need to go out and
Yes,
then come back in again and yeah.
it's just booting. Sorry about that, guys, but
No, it's okay. It was really interesting, the survey, actually. I'm glad we
okay.
all knew to get emergency contraception because that's very vital. But it's interesting that it's 45% of
Exactly.
pregnancies are unintended. And yeah,
So
it'd be really interesting to know what we can do about that for your talk.
so I let me present again and then we will present and then yeah, and then we can hold. Am I still sharing my screen?
Yep. I can see your mouse moving now. So, oh,
Yes.
yeah, there we go. We're on. We're
We
working.
go. Got that
Brilliant.
in the end. So now let's talk about the different methods of contraception. So natural methods, like I said in earlier on, fertility awareness-based methods, some of the natural methods for people who don't really want to use devices or medication, but it does involve committing to this. And it involves tracking your menstrual cycle. And there are apps now that can help track your menstrual cycle, your basal body temperature, and cervical mucus thickness. But again, these methods are very, very objective or subjective, I would say, and very much depends on the woman's commitment to doing using that method. There's the lactational amenorrhea method, the LAM, which is effective for up to 6 months postpartum if exclusively breastfeeding. And the key word there is, or the operational word is exclusively breastfeeding. If you give a bottle of milk occasionally, that method is not going to work for you. And we've seen several occasions where women with babies who've just had babies have come back 3 months after and they're pregnant again. Then there are the barrier methods. So a lot of us know and associate contraception to condoms, but condoms is not just one group of condoms because there are male condoms and there are female condoms. And barrier methods also include diaphragm and cervical cap. They are quite effective when used properly, and they can also they have the additional benefit of preventing sexually transmitted infection. So for male condoms can be If you use it perfectly, it can be 98% effective, but most people don't use these things perfectly, and either they get they rupture, or perhaps using oil-based gel on them or lubricant on them will make them less effective. Female condoms are 95% effective when used perfectly, and it gives the woman a bit more control, but it depends on if herself and her partner are willing to, are satisfied with using the female condoms and also the male condoms. And the cervical cap used with a spermicide can be 92 to 96% effective. Regarding condoms or barrier methods, what there are do's and don'ts. Use a new condom every time you have sex. That's a do. Follow the instructions on the condom pack to put it on correctly, because inappropriately administered condom is one of the reasons it fails as well. Check the use by date and ensure it's not expired. And then obviously check that it's European CE or UKCA marked. That means it's been tested to a high safety standard. Do not use more than one condom. This can make one or both condoms split. Do not use oil-based lubricants with latex condoms. Use water-based or silicone-based lubricants instead. So that's that for barrier method, just a whistle-stop tour. But for the hormonal contraceptives, there are different categories and classes. So the ones that are hormone-based, the hormonal contraceptives are the combined hormonal contraceptive, which we commonly know, and which was probably the one that was, like I said earlier, one of the earlier forms of hormonal contraception introduced. We have them now in the pill form, the patch form, and the vaginal ring. They contain estrogen and progesterone. That's why they are combined, and they prevent ovulation. So they're not suitable for everybody, though, because some women who are smokers and are above 35 years, or those with high blood pressure, or those who suffer with migraine, with auras, are not really good. They're not suitable for using such people. So in that sort of scenario, another option would be to use the progesterone-only contraceptive, since the combined form seems to be unsuitable for certain class of women. In those women, you can use the progesterone-only contraceptive. So for those who cannot take estrogen, you can use this, and it can be in the form of the tablet or the injectable. So Depo-Provera and Ciana Press are the ones that are available in the UK. And you take the injection every 8 to 13 weeks. But for the progesterone-only pill, you would take it for about 21 days, have a few, I think about 3 days rest, and then continue. Or sometimes you can back-to-back the pills as well. The only slight thing about them is that they can cause you to have menstrual irregularities. You might be having spotting, unintended bleeding in between your pill-free periods. So that usually discourages a lot of women from using them, but they are quite effective when used properly. And now moving on to the third class of hormonal contraceptives, we have the long-acting reversible contraception. So the implant, the variety available is Nexplanon. This lasts for about 3 years and it's about 99% effective. There's the copper device, although not hormonal, but it's just to let you know that there are other sort of devices. And you can see from the pictures here, there's the intrauterine device that has the hormone, and then there's the subdermal patches or the Nexplanon, and then there's the Mirena, Kylena, or Jades. So that we call that the baby Mirena, the Jades, because it's a bit small, and the dose of progesterone is a little bit lower than that you will find in the Mirena coil. So they release progesterone. They last for about 3 to 5 years. From Jades will last about 3 years. Mirena will last 5 years. And they're quite good at reducing heavy menstrual bleeding. And now for the implant, which I said is very effective and can last 3 years, it's put under the skin, usually in the inner part of the upper arm. But when you take it out, just to be aware, once it's removed, you can become pregnant, even though they would say wait a little bit of, wait a little after taking it so you can have a time frame when you want to conceive, but you can't fall pregnant as soon as you take it out. So if you don't want to get pregnant, try and use barrier methods or other methods of contraception, depending on how soon you want to start trying for a baby. And if you do have unprotected sexual intercourse and you feel like this is not the right time to get pregnant, you can always speak to your pharmacist, sexual health clinic, care providers, your GP, or even call the 111 for advice. But yeah, it can affect the implant itself, can affect some emergency contraception. So you need to speak to a specialist before taking them. Okay, so permanent methods. So there's the female sterilization. These methods are not reversible, especially under the NHS. Some people do get them reversed privately, but the NHS doesn't cover that. So it involves, well, basically tying up. When we say tie, we don't necessarily mean that we're going to, put a knot in it. We just put a clip or we cut it or burn it. That's what the word cauterized here means. You use the electrical energy to burn off the cut ends of the tube so that they don't, there's no continuity, and then the eggs cannot cross or the sperm cannot cross and fertilize the egg. So it can be a band or clip. There's the fail sheet clip, which we normally use. There are metal clips. Well, they've got silicone coating on them. So they apply them laparoscopically. So this will involve surgery, but sometimes we do it during cesarean section, although the failure rate would be a little bit higher if done at the time of cesarean section. But when done outside of pregnancy, the failure rate is about 0.5%, which is about 1 in 200 women. Now compare that to the more permanent method, male sterilization, which is vasectomy. That blocks sperm transport and is simpler to do than female sterilization. You can do it as an outpatient procedure. And the failure rate is about 1 to 2 in 1,000 people. So lower failure rate than the female sterilization. However, caution has to be applied for the first 3 months after male sterilization because some already formed sperm may still be present in the ejaculate at that time. So it'd be good to use protection like condoms during that period. So this is a quiz, not a QR code this time around. Which contraceptive methods are the most effective, given all that I've just said? And you can put your answers in the chat. I'll give you like 30 seconds and then I'll reveal the answer. Any responses yet?
Yeah, so there's a couple in the chat. Somebody mentioned Lark. Somebody mentioned condom. There's implant, vasectomy.
Okay.
Somebody else also mentioned that it varies from person to person.
Okay, that's a politician. Yeah.
Very political. But then they've come back and said potentially the IUD might be the most effective.
Okay, so the most effective ones are the implant and the IUDs, like they rightly said. The sterilization, the vasectomy is permanent. So in terms of these other non-permanent methods, the implant is very, very effective, and the long-acting reversible contraceptive options, which include the IUDs, are also very, very effective, and their failure rate is less than 1%. So if you don't want to have a baby, you don't want to use, or condoms are not really your choice, and you want to space or plan your family, then you can use either the implant, you can use the Marina core, because taking tablets, not everyone really likes to swallow tablets as well, or take injections. So these are actually quite successful. Now, so all of this that we've been talking about, contraception, the different methods, the history, is aimed at giving women power. over their fertility. Nobody wants to control women, but it's quite interesting. I was reading through the history of Planned Parenthood in America. They're about over 100 years now, and their journey involved a lot of opposition and legal action, and even in some cases, people were being taken, court actions were being taken. Um, and it just made me feel like all women wanted was a way to control how they their families and the way they plan it. So contraception is aimed, or family planning is aimed at reducing the risk of complications from unintended pregnancies. There's a sad story I saw recently, but this was in Nigeria actually, where a baby was found with his umbilical cord still attached, just dumped by the riverside. And the baby was picked up. And obviously that was from either a teen mom or someone who was definitely hiding the pregnancy and didn't want them to know that she had birthed the baby, which is quite sad because there are people out there who are equally crying their hearts out to have a baby. And you would just think, oh, why do such people get pregnant so easily and others struggle? But the key point here is that pregnancy should be something that you should plan for and be ready for. Give birth to the number of children you feel you can look after. So to help with this, contraception and other methods of spacing and planning family were being advised and recommended, and hence the innovation and further innovations are taking place to help women with this. And also men, because now they're researching into male contraceptive pills to help to work similarly to what the female contraceptive combined pill would do. So this reduces maternal mortality and unsafe abortions. It also allows women to space pregnancies, leading to healthier outcomes for both the mother and the child. And it enables women with medical conditions, for example, hypertension, epilepsy, cardiovascular diseases, and diabetes, to plan safer pregnancies, because sometimes you have congenital abnormalities because these conditions have not been well controlled. Or, for example, hypertension, she develops complications and could have preeclampsia or even eclampsia and suffer or die from this if her pregnancy is not well planned. Okay, so key thing here, women need to have control over their fertility, and these are just ways to help them have that control. It also has social impacts. When women are empowered by providing reproductive autonomy and improving and giving them this power, enables them to achieve academically and take their careers forward and personally develop themselves and become positive players in the society as well. It reduces financial strain on families by allowing better planning for children's needs, and it helps communities by reducing the burden on healthcare systems and improving overall well-being. There are controversies. There are people who don't believe in contraception, and we respect that because of their religious affiliations or personal choice. We encourage personal choice, but it's also of note that if you decide that you want to do something about taking charge of your fertility, there are options available. And there's also the option, okay, we're in the worst case scenario, you feel you've had unprotected sexual intercourse, you don't want to get pregnant, like we rightly said before, there's the emergency contraception. So those other methods I've discussed up until now are things you have to plan for and go and get to see your healthcare provider, your GP service or not. But for the case where it's completely unintended, maybe you've had a few too many drinks at the weekend or feeling too happy, and it's happened, there are things to do. So the levonorgestrel, is called Levonel or Plan B in America. It's an emergency contraception that is progesterone based as well, and it can be effective for up to 72 hours after you've had unprotected sexual intercourse. There's Ella1, the pharmacological name for that is ulipristal acetate. That's also effective for up to 5 days after unprotected sexual intercourse. And then there's a copper coil, which is the most effective actually, and can be used for long-term contraception after insertion. Okay, So this is just a table that shows you a league table for emergency contraceptive options. So leading the table with copper intrauterine device, almost 100% effective. And you can put it in as soon as or within 5 days of the unprotected sexual intercourse. And also to note that it has to be placed by a specialist. So you need to go and see your healthcare provider to get the copper inserted. And you can get it from your sexual health clinic as well. And when you say it's for emergency contraception, that should be scheduled quite quickly. There's the Ella one, like I said, that's the second ranking. You need to take that ASAP, but you can within 5 days at most. And again, it involves swallowing tablets, and you can get an extra pack for the eventuality that another incident of unprotected sexual intercourse occurs. And then there's the Levonel or the Plan B. Again, similar to the Ella one, you can take it, but this time you have to take it within 3 days. So as soon as possible, but at most 3 days after unprotected sexual intercourse. It does involve swallowing pills, and not everybody can take LL1 or Plan B, especially if you are obese. So that kind of reduces the effectivity of these two options. Hence, they're placed second and third. Okay. So let's talk about some myths and misconceptions about contraception. Some people will say, no, I don't want to take it because I heard contraceptives make you infertile. No, they don't. As soon as you stop the fertility method, it returns. The only one you cannot reverse is the tubal ligation, or when you sterilize your tubes. If you need to get that done outside of the NHS here, and there's a risk that you could have an ectopic pregnancy even after reversing it. The intrauterine device, another myth is that intrauterine devices are unsafe for young women. That's not true. They are safe for all ages, including those who have not given birth. And then lastly, birth control causes long-term weight gain. The evidence is not saying that it doesn't, but minimal weight gain. So this should not be a reason not to use the contraception, the hormonal contraception. Yeah, so any questions for me? I hope that has enlightened people, and it's a whistle-stop tour on contraception. But I think what I was trying to highlight is that there are different options. This has been going on for a long while, and there will continue to be innovation, and women will continue to be supported in their choices. Thank you very much.
Thank you so much, Dr. Okojie. That was very informative. I really liked your slides. They were easy to follow. And yeah, it was really packed with lots of information. I think that when you mentioned about the social impact of this and how it's important for women to be able to take control of their lives and their fertility, it's such a powerful message. And also the harrowing story of the mother who left, the child by the roadside. It really goes to show how important this is, and it's a very key problem that needs to be addressed. Um, and I was also really surprised about how far we've come in the journey of contraception from using intestines and like,
Intestines of
yeah,
pigs,
as good. That's really
of
fascinating
fish
to where we
bladders.
are now.
Yes.
Yeah, it's interesting because I think I've got a couple of questions and I think I'll read through them as well. But I think first thing is there's lots of options, right? And very often when I see a woman in clinic, it's really difficult because there's so many options and they don't know where to go, what causes what side effect, what should I do? And I just wondered if firstly you had any sort of good resources that to signpost people to as a decision aid,
Yeah.
because it can be very, very confusing to navigate.
Yeah.
Um, that was my first question, and I have some other ones, but I'll let you answer that if you
Yeah,
want.
so my go-to site would be the NHS
Okay.
website. So it depends on what stage you are at as well. If you're pregnant or you've just had sorry, if you are not pregnant and you
Hmm.
want conception, or if you've just had a baby, you're thinking about contraceptive options as well. So
Hmm.
in the antenatal clinic, for example, I tend to broach the topic with women and say, like you've got have you thought about contraception and what your choices will be? And I will go to
Mm,
the NHS resource site for postpartum contraception because
mm,
some of them can be administered immediately after delivery, and some
mm,
you have to wait until your 6 week or 12 week check to get them
mm.
put in. So it's quite good to start talking about those things.
Definitely.
And then for those who don't, who are not pregnant and want contraception, there's a sexual health clinic that you can also go to. Uh,
Brilliant.
apart from the NHS website, there are lots of resources out there that tell you what is available. But I would still recommend going to your GP, having a talk with the GP. We need to make sure you don't have any contraindications to
Mm,
in one form or the other. But the ones that are not hormone based, some women are just come in and say, I don't want to put on weight. I don't want anything with hormones in them.
yeah,
So, and then some people say, no, 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 I don't want to put anything in me either.
exactly.
So, you need to think about these things. And like the other um, scenario of those having comorbidities,
Yes.
normally we would like a situation where these morbidities, especially if you've known about them from childhood all the
Hmm.
way till before when they get into the adolescent and reproductive age, we've
Hmm.
started planning
Hmm.
a journey for them.
Yes.
Women with epilepsy, people that have got migraines with aura, you already
Mm,
know, and you're planning, and you want to
mm,
plan their pregnancy, or people with cardiovascular disease, you want to plan their pregnancies for them. So
mm.
assessing them and using the right option for them is very important. It's very important that they don't get pregnant unintentionally.
So, yeah. And it's interesting because very often we don't talk about these things early on. It's when something has happened, then everyone's trying to rush. So I think having that plan from very early on is very helpful, especially for people who have comorbidities, like you mentioned. So thanks for that answer. Then my other question was around the high rates of unintended pregnancies. And I just wondered if you knew if those unintended pregnancies were also, well, how sort of split it was between people who were on contraception and people that aren't. Because very often I also find that people that are on contraception, just how you've mentioned, you can obviously use things like the pill, for example, but very often people forget to take a pill here and there, and it's the efficacy of that then ends up just reducing because people aren't really like taking it at the right time. And there's been like, I think in terms of the longer acting contraceptives, there was a fall in uptake for a little while, and I think it started to pick up again. But I just wondered whether that's something that you would try to encourage more for people to use, because I know there's some concerns about, or having something in my body, and there are some questions that are popping up already about, do they cause cancer, can they do this? But I suppose my question is, should we be trying to push more for longer acting reversible contraception than the user dependent ones?
So
Yeah.
the success rates I quoted are for typical use. So those who are very, disciplined about using those methods. So because the condom doesn't work up to 98%, it's about 65% effective in reality. And
Yeah.
you see people who fighting each other because, like, it's not my baby. We use protection.
Mm,
Actually, it is because that's not 100% effective.
mm,
And then there are those that miss the pills. There's advice, which is why you should see your healthcare provider as well, because they can advise you on what to do if you miss your
mm,
pill and all
mm.
of that. But again, to avoid all of that, the longer acting ones where you don't need to think too much
Exactly. Yeah.
should be something that we should encourage. And they do not cause cancer. So that's a categorical no for
Yeah.
me.
Okay.
However, funny enough, the Mirena coil is actually used to treat endometrial cancer.
Mm, okay. It's really helpful.
Estrogens are actually, the progesterone only. The class of drugs that we can use that are actually used
Mm,
in the treatment of endometrial cancer or atypical endometrial hyperplasia.
yeah. That's really helpful. I have one more question later on about men, but I'll come back to
Okay,
that then.
we like to include
Um,
the female as well.
but I think one of the very first questions that I got asked was, is it normal for the IUD string to stick out and if it's not normal, what should be done when it sticks out?
Oh, that's an interesting question because it depends on how how they cut the string at the time it was fitted may have been too long and didn't notice at that time. But then again, if the strings were not noticeable previously and now you're noticing it, it means that it's probably displaced.
Mm,
You should go and see your GP. You probably have an X-ray done or
mm.
an ultrasound scan just to see if it's sitting properly or not. One of the problems we find with displaced coils, for example, the Mirena coil, is that you can actually get pregnant if it's not sitting properly. And one of the things that would be causing that is if you've got like a fibroid womb
Yeah.
that's really distorting the cavity, so you can really fit the marina properly. That will be
Mhm.
one of the reasons it gets dislodged. And if it's not sat properly, sometimes it falls out, and some women bleed heavily. Or for women who are bleeding heavily, they can bleed it out with the monthly blood loss and
Without realizing.
not realizing, and you think,
Mm.
my periods haven't stopped, then your marina has fallen out at that point. But
Yeah,
one thing we do is encourage people to check the strings
exactly.
regularly. Okay.
Exactly. Yeah, that's very vital because, like you say, anything can happen with it. So you have to regularly check. So I'm glad this person is checking, but I hope that answer from Dr. Koje is helpful. Thanks, Ruth, for helping to collate the question. So the next one is, do contraceptives exacerbate fibroids? It took me more than 4 years to get pregnant again after the implant. I think there might be slightly two different questions, but they were linked together in the same. So does contraceptives exacerbate fibroids? And
No,
I guess you've no, it doesn't. Okay, there you
no,
go.
it doesn't exacerbate fibroids, and that delay in fertility, number of issues, the age could,
Hmm.
which is the main factor in fertility, could have been playing a role. And I don't know what else the context of that person would be, but um, the cause should not be causing your fibroids to grow.
We use it to treat, actually, like like if you're having heavy periods from the
Heavy periods from
yeah, we
fibroids,
treat
you
with
use
the
it.
contraceptives. Yeah,
The
so it's
combined
actually
pill, which has estrogen as well,
hmm
you use it to treat because it
yeah.
suppresses your brain center that produces and in charge of releasing hormones. And when
Hmm.
you have the hormones, the uterus from its hormonal uh,
Hmm.
threshold, things tend to settle. For example, the lining of the womb thins out, and that
Hmm.
is very good because then it makes you amenorrheic, so no more
Hmm.
periods or very light period bleeds. Hence,
Yeah.
for heavy menstrual bleeding. But no, it doesn't cause fibroids to grow. No.
Brilliant. Thank you for that answer. Other question is I guess you've answered the question of does it cause cancer? So that one's gone. Another question is does IUD make women fat? And just linked to that as well is can implants or pills cause fatty liver?
Oh, okay. IUDs don't make people fat
Hmm.
because the benefit is that it's locally acting, not systemically acting, like unlike the tablets.
Hmm.
I did say that the evidence is suggesting that weight gain can occur, but it's not as much as people think or ascribe to the pill. The implants can make you have quite irregular periods, and it can cause thinning of the bones in very young people, like those under 18 or 18 and above. So we would tend to be cautious in such group. So we are going into the final details now, the FSRH MEC categorization. But again, the reason you need to speak to your healthcare provider, okay?
Hmm.
Because you can use them, but even in people who are obese, you can, but the use would be very cautious.
Hmm.
Some extreme cases, absolutely contraindicated. But
Yeah.
weight gain, and that weight gain is usually at the early stages of its use. Once you've used it for a steady, you've gotten to a steady state, that weight gain becomes because of what you're putting into your mouth, not so much the implant. And then for the, I think they said cancer, or what was the last?
Yeah. But I think you've answered the cancer question. It was about fatty liver.
The fatty liver. It shouldn't cause fatty liver, but if you've got a liver disease, you may not be suitable to take hormonal-based contraception.
Mhm. Brilliant. Thank you very much. I think you mentioned something about young people just then, and I was just thinking if you've what your experience is with, especially for our community, the Black community, um, young people on contraception. Is there like a barrier? Is there like a stigma attached to it? What's been your experience of managing young African or Caribbean children or younger
If
people?
you remember, we're all coming from our microcultures,
Mm,
and we came into, or in the UK, we are still coming from a community that had certain belief systems.
mm.
So I can give you the Nigerian, um, even the thought and the mention of contraception.
Yeah,
You're already classed as promiscuous, you are wayward, you are this, you're that. Even going to buy sanitary pads from the store can be
yeah.
stigmatized.
Mm,
I want to talk of contraception, and then when you're on contraception and perhaps suffering side effects like acne and the rest of them, although newer pills have less acnogenic effects,
mm,
they're like, oh, she's wayward. Oh, look at her
mm.
medication. Oh, she's already having. Uh, okay.
Don't get started. It's difficult because we want to plan things early, but when you can't
Yeah.
have the conversations early enough,
Yeah, we
it's
should be
difficult.
encouraging
Yeah,
our children
yeah.
to have these conversations. And the reality is that they are having sexual intercourse.
Yeah,
It'd
yeah,
be nice if they could abstain, but
yes,
the world out there, they are being influenced by culture,
yeah,
the wave of and the trends of time.
yes,
So we
yes.
need to help them to be cautious because England actually has one of the highest teenage pregnancy rates in the world,
Okay,
or
okay.
in Europe, in
Hmm.
Europe. And
Hmm.
I'm asking myself, why is this happening?
Hmm.
All these contraceptive options are available. Why
Hmm.
are they still getting pregnant?
Hmm.
So it's not just the contraception is just one part of the chain. We need
Yeah.
to address other social factors as
Hmm.
one of the contraception should be part of that discussion.
Yeah.
Girls especially take control of their lives.
Yes, absolutely. I completely agree with that. And I think as well as addressing the social factors, I think something else that I've also noticed is very often women that are either on the coil or the implant, they very much struggle with getting access to if they want to get it changed, for example, like getting appointments at the sexual health clinic. I think it's a huge challenge for them. Like they might find they have to wait on a queue on a call for ages. And I think GPs don't often have those kind of long-acting contraceptives. So I think sometimes there is a slight access issue as well with
Yeah.
those. But I suppose it's something that we need to think about as a system, how we can make it more available and more sort of normal in our communities.
And if you think about the socioeconomic strata, the people who need it the most are those in the lower socioeconomic band.
Mm,
So, and they're the ones who have the most challenging access to having these interventions
yeah.
because the system is not catering for them. Like you
Mm,
rightly said, some people are on the waiting list for 3 years for contraception.
mm. They
The
couldn't get pregnant, man.
and you can have like 2, 3 children
Yeah,
after, and you're like, what the heck? I don't need it anyway. So
absolutely. Yeah.
at that point, you have taken away her choice. And I think
Mm.
it's something that we need to highlight and we need to call out and help our people also um, advocate for themselves.
Yes, absolutely.
Don't, don't take it. If they don't have an appointment, they can send you to another. You do have a right to a second opinion
Absolutely. Yeah.
anywhere in the UK, even if it's Glasgow and you're based in Kent or something. You want a
Mm.
second opinion? If it's
So
available in Glasgow, go there. They should
amazing.
be referral.
Amazing. Amazing. I need to round up in 2 minutes. I'm going to ask two questions. One of them was from YouTube. How does the Mirena coil help with fibroids? What is the connection? Because some say pregnancy could help reduce fibroids.
Ooh. Mirena helps with fibroids, especially the submucosal fibroids that cause a lot of heavy bleeding. So once you can fit it properly, it helps. The Mirena helps by causing the lining of the womb, which is shed every month, to thin. Okay, that's the direct effect of the progesterone in the Mirena coil. The copper coil will not do that because it doesn't have any um,
Hormones.
hormone in
Yeah.
it. The copper is toxic to sperm and eggs. That's why it's very effective. But for the lining of the womb, the thinning is Mirena. So if you have a submucous fibroid causing a lot of bleeding and you can fit a Mirena coil, that's going to reduce. with time. Okay. And then the second part about pregnancy causing fibroids to reduce, that's not true. Because in pregnancy, a fibroid could grow because it depends on the same hormones the baby depends on to grow, estrogen and progesterone. Okay. So that combination could make fibroids, especially those about 5 centimeters and above, they tend to grow the most in the first phase of pregnancy. And then the smaller ones, like 2 centimeters, 3 centimeters, they tend not to do that, follow that pattern. Okay. So, but then again, fibroids can stay the same in pregnancy or not even grow. Maybe they've just outstripped their blood supply and they've died off. So
Brilliant.
that's,
Brilliant.
so it's not such a straightforward connection.
Yeah. Thank you so much for that. And I guess very quickly, my last question was around men, because this conversation has been a lot about women, but I also
Very
feel
female
that,
based.
yeah, I feel like we play a major role in terms of vasectomies. I know the male contraceptive pill isn't here, but just any small advice regarding that, because I feel that it takes two to tango, and we need to have our role also in this. So just wanted a word or two from you, and then we can round up. Yeah.
So from the Afro-Caribbean society, I don't think that's something that's quite popular, but I do see it amongst the Caucasian cohort of people.
Yeah.
The uptake is higher amongst them.
Yeah.
And I don't know, maybe it's the cultural thing as well, where men, their virility seems to be their badge of honor. We need to encourage our men as well.
Yes, yes,
You can't stop men from being men and doing things that men do in secret or in the open, but just be wise as well.
Yeah, yeah.
Would be my advice. Yeah. And there are choices, there are things available to do as well.
Thank you so much, Dr. Okojie. That was very informative and just very easy to follow and understand. Really appreciate your time this morning. I will pass it on to the CAHN team and then we can round up. Thank you.
You're welcome. Thank you.
Can everyone see my screen?
Yeah.
Yep.
Right. Thank you very much. Thank you, Dr. Aziz and Dr. Tapua, for the wonderful presentation. It is really, really informative for me, and I learned a lot of things. And as a lady, it is actually very important for us to take ownership of our lives and how we plan our pregnancies and how we plan to have children and, raise those children. So it is really important, and it's a very important topic as well. Thank you for responding to those questions as well. So for CAHN, we're going to have the same health hour next week, same time on the 8th of March. So the topic for next week will be women's health and chronic kidney diseases, which is going to be, our guest speaker is going to be Professor Ibi Ekerosina. And it's going to be really, really informative. If you want more information, you can either register online or scan the QR code. And you can also share this with your network, because I'm sure all of you who have been in this webinar today can see how informative and empowering it is. So it is an opportunity for us to come and learn a lot of new things and take ownership of our health and well-being. And as CAHN, we do a lot of work around women's health. And next week, it's our International Women's Day, which is about womb health in digital era. And our keynote speaker is Professor Margaret Ipo, and it's going to take place at 3 Archway Humes on Friday. Please circulate this with your network. You can also scan the QR code and register also on Eventbrite. And it's on Friday, the 5th of March, 2025. And it's an opportunity to come and celebrate the women in our community with a special focus on womb health in digital era. So this event is completely free. Come, let's honor the women in our lives. And again, coming together in hope. So we're going to have a day of reflection, COVID-19 nationwide service for Black communities. And we cannot agree how COVID-19 took a great toll on each and every one of us. And it's an opportunity for us to join, to come together on the National Day of Reflection for Black community affected by COVID-19. So this service is going to take place on Sunday, on the 9th of March from 7 p.m. to 9 p.m. You also have opportunity to join online. And if you're in Manchester, it will be a great opportunity for you to also come to Manchester Cathedral. So you can also scan the QR code on my screen and also be part of that service. If you're unable to come in person, you can also join online. So at CAHN, we also support the community in different ways. So baby loss bereavement support, we know what it means to lose a child, and we have a very good opportunity for you to, if you've recently lost a baby or miscarriage, you're not alone. Remember that you can also join our free online bereavement session of cultural sensitive grieving, counseling support group and resources. So this session will hold next Thursday, which is 6th of March from 6:30 p.m. to 7 p.m. You can either register with the QR code on my screen or also reach out to Rosalind at CAHN.org.uk. We have different sessions. We have on the 5th of December, we had 19th of December. So the next one is going to be after the 6th, is going to be on the 20th of March. So please, if you have anyone who have lost a baby and is going through bereavement and they need that support, you can refer them to this as well. So we also have another bereavement support group, which you can have if you have recently lost or experienced loss or dealing with grief. You can also join our online bereavement session for families and individuals navigating grief, which is from the 10th of March. From 7 p.m. to 9 p.m. It's an opportunity for you to come out and, get that support that you need that is culturally appropriate for you. And you can get people who also understand you better and can give you all the support. You can also scan the QR code on my screen, or you can also reach out to Rosalind at CAHN.org.uk. And the session starts from 7 p.m., like I said, to 9 p.m. online as well. So please share this with your network, because we all are grieving in different ways and you might not know what someone might need at a particular time, but this can be really, really helpful. I've been to those sessions and I know how supporting it can be. And for a Black community, you're not allowed to, grieve, especially for a man, because you are a man, and this can take a big toll on you. And this is an opportunity for you to also come here and grieve as much as you can. And at CAHN, we also have the Green and Art Wellbeing Services, which is for you to come. It's an opportunity for you to join us to create and celebrate well-being with Caribbean and African inspired activities like painting, nature walk, and more. So this session holds every Wednesday at our Bolton hub, or every Tuesday at our Stockport hub. So details of the Stockport and Bolton hub are also on the screen, and you can also scan the QR code if you want more information. You can reach out to Lola at health. You can also reach out to Lola or email greenandartswellbeing@CAHN.org.uk or call the number on the screen. Please circulate these services with all your network, because we do all of these things for the community, and it will be very good for our community to benefit from this. It's always good to always, let the community take ownership of their lives and know what's available to them to be able to support their health and well-being. So please, all of the services I've circulated here, please, it is very, very important, and it should be an opportunity for you to support your own network as well. So circulate with your network. And thank you today again for joining Health Hour. And we hope to see you all next week for another informative session with, like I mentioned, on women's health and kidney disease. So thank you. I hand over back to the marketing team. Back to you, Ruth.
Welcome to our Caribbean and African Targeted Health Improvement Program, CAHN Health Hour. The Caribbean and African Health Network, CAHN, along with its national partners, are incredibly pleased to continue to bring to you targeted health and well-being education delivered by Caribbean and African doctors. These health hours are all about empowering, educating and giving space to Black people so our communities can look after themselves better. Every Saturday, our Black GPs or consultants present on those health and well-being topics that affect you, your family members and friends. Some weeks will vary and will include other panel members such as pharmacists, specialist nurses and faith leaders. Our health hours cover a range of topics and include mental health, heart health, women's health, reproductive and sexual health issues, men's health, respiratory problems, cancer, sickle cell and many more. We have not forgotten to include within our health hours the many societal, cultural, religious and racial challenges that can go hand in hand with health problems and influence how we should respond to meet health and well-being needs. The sessions are designed for you, and we want you to use the time to listen, learn, share your experiences and ask questions to our Black doctors. During every session, we will gather your feedback so we can continue to respond to the needs of our Black community. To request any particular topic, please email health@cahn.org.uk. We encourage you to invite others to our health hour sessions. Spread the word in our community. CAHN is funded by the National Lottery Community Fund.